Well, some of you may remember probably 2 months ago I did an impromptu presentation about Northwestern. And one of the things that I couldn't answer a bunch of questions about was the Doctorate of Nurse Practice program, which is a phenomenal new program for Northwestern. And I don't want to take too much of past thunder, but this is the first doctorate level program in the history of Northwestern. A big deal. It's also a big deal for our community because it's going to center around rural health care, and that is going to be critical for our future, and it's going to be a national issue, I think, and we're going to be at the heart of the beginning of this. Dr. Pat Thompson, I don't know her very well. I've got a chance to talk to her a little bit. She has a neat background story, how she ended up out in the western Kansas that I hope she'll share with us. But please, would you give a warm welcome to Dr. Pat Thompson.
Kansas half my life. Born and raised outside in the suburbs of Philadelphia. And I was working in Washington, D.C., and a friend of mine who I went to college with worked in Washington, D.C. and met a really neat guy who had gone to Heston, a Mennonite. He was a respiratory therapist, and his asthma was really bothering him in Washington. And he decided to move back to Kansas. She ended up marrying him, and they did not have a health department in Barber County. That's Medicine Lodge. They had a $15,000 grant from the state, and they wanted somebody to come and set up this health department with a home health agency. And I was working at the National Institutes of Health, doing a lot of, they do a lot of research, as you know, and I was working with patients who had open heart surgery. And Patty told me about this job. And being a snobby Easterner, you know, everything west of Philadelphia is the outback, including Pittsburgh, Pennsylvania. And very idealistic at age 25, and Medicine Lodge, Kansas, and the people that I knew out here told me that there was a large Indian population, which I bought hook, line, and sinker, and I'm thinking domestic violence and alcoholism and diabetes, and I'm going to go stamp out disease out of Florence Nightingale. So I came out and I interviewed. Before I interviewed, I came out like in October, and the wheat was coming up, and we're driving out of Wichita toward Medicine Lodge, and I looked around and I said, "Who mows all this grass?" I have come a long way. I really have. So after the interview, I said to the physician, I said, "I understand you have a large Indian population." And he said, and he started to laugh. He said, "Well, we have one guy in town, Charlie Little Coyote. I can bring him in to talk to you if you want." In fact, Charlie Little Coyote just died about 3 months or 3 years ago, something like that. My husband, who is a Barber County native, told me, "Don't call them coyotes like an Easterner. They are coyotes." Okay. So anyway, that's how I got to Medicine Lodge, Kansas. Met my husband, lived there for 4 years, met my husband. He, in the meantime, had moved to Parsons to start working in manufacturing. And then I ended up teaching in a community college over there. 4 kids in 5.5 years, because we were really old when we got married. We were 29 in wheelchairs. And so I've done a variety of things. At the age of somewhere in my 50s, I've forgotten when, I've been a nurse practitioner for 10 years, I decided that I would like to finish out my career being a nurse practitioner, now that all the kids had left home at that point in time. But growing up in the 60s and 70s, you know, there weren't a whole lot of choices available for women. It was nursing and teaching and a stewardess on an airline and a secretary and those kinds of things. And the females that I knew, most of them who were physicians or lawyers or whatever, either never married or they were divorced or they had a house husband, and I didn't want that. So I kind of delayed that career goal for a lot of years. So I've been a nurse practitioner for 10 years. Before that, I was a nurse educator for many, many years, which worked really well because the schedule kind of dovetailed with that of the kids. So this is a little presentation that I put together for the Dean at the Woodward campus back in the fall, and I have changed it a couple of times since and updated it a little bit. Wasn't sure what the capability would be for projection, so you have some slides there. We are 49th in the state in Oklahoma in terms of the ratio of physicians to patients, which means our health outcomes in Oklahoma are truly awful. Probably sort of like Alabama, Mississippi, Louisiana. Part of the problem is being rural. In northwestern Oklahoma, in some counties, we have one provider for 3,000 patients, and that is a big problem. Of course, we have an aging population too. 64 of Oklahoma's 77 counties are designated as federal shortage areas for primary health professionals. Okay. Job market is really good for nurse practitioners. Probably about a 35% increase predicted for by 2024. Nurse practitioners, we all think we have the best job anywhere. Nurse practitioners have been in existence for over 50 years. When I was in my baccalaureate program back in 72 through 76, nurse practitioners have been around for about 10 years in rural areas like Minnesota, North Dakota, South Dakota, primarily to take care of the rural population. As you know, it's extremely difficult to attract physicians to rural areas. And not to step on any toes, but one of the big problems, having been involved in recruitment efforts, even in Southeast Kansas, which is where I live, is, you know, physicians' wives do not want to be 2 hours away from a big mall. They just do not. And if you have to go to Denver to the mall or drive all the way to Tulsa 2.5 hours to the mall, that is really a problem. You have to love living in rural America to stay here because it is inconvenient, and we think it's the best kept secret because, like, I drive in from Medicine Lodge, 37 miles or 39 miles, 40 minutes versus just got back from Washington, D.C., drove 37 miles into Washington, D.C. It takes like almost an hour and a half. So we can just keep those people on both of those coasts. Okay, so nurses are prepared as expert scholars and healthcare leaders at the highest level of advanced nursing practice. We are needed at all levels, federally and state. Current education. Oklahoma, I don't know how many years ago, but it has been probably within the last 10 years. It used to be that you could be an RN in Oklahoma and then go through some certification courses to become a nurse practitioner. They moved that to a master's level, and that's where it is nationwide at this point in time. You have to have a master's degree to be a nurse practitioner. Several of the schools in Oklahoma, including OU, have master's programs or postmaster certificates to prepare their nurse practitioners. But now we come to the evolution of the DNP degree. Back in 2004, national nursing organizations and federal agencies identified the need to really move nurse practitioner education to a doctoral level. This has not been mandated that it requires a doctorate, but having just come back from Washington, it is definitely on the horizon. This would kind of equalize us with other practice doctorates. If you are an MD, that is a practice doctorate. If you are a vet, that is a practice doctorate. If you are a dentist, a DDS, that's a practice doctorate. If you're an optometrist or a chiropractor, all of those are practice doctorates. Even now, pharmacy, that's a PharmD, and podiatry, those are all practice doctorates. So that kind of puts us at that level, which gives us a whole lot more credibility at the policy table, talking about policy, but also additional education to take care of patients. So what's the difference between a DNP, a Doctor of Nursing Practice, and a PhD? A DNP is practice-focused, application of research. So we would take current guidelines of how to take care of somebody with diabetes or high blood pressure or arthritis or the common kinds of things that we see every day. We would take those current guidelines and apply them to our practice and even do some research with how to take better care of the patients. In contrast to somebody with a PhD, that's a Doctor of Philosophy, they have to do original research to do their dissertation. One of the interesting things about PhDs, somewhere around 35 to 40% of PhD candidates are ABD. ABD stands for all but dissertation. So that means that only 50 to 60% of them actually graduate and are awarded the PhD. The dropout rate is pretty phenomenal. And it's everyone I have talked to has gone through a PhD, including a lot of the Northwestern people, have said, oh my word, this is a really difficult process to go through. But you will see a lot of nurses that are PhDs, but this DNP degree has been around for several years, and that is what we are going to be doing at Northwestern. So how did the DNP come about at Northwestern? And Skeeter, you would probably be better to even talk about this than me. This predated me. In January of 2016, the Oklahoma Board of Regents approves the establishment of the first doctoral program, and it really came out of a grant or an endowment from the Charles Morton Share Trust, and then that was bolstered with additional endowment money of $2.5 million from the Wisdom Foundation. Did you want to add anything to that? That's pretty much that was in the press release around that time. That is what has enabled Northwestern to implement this program. And the whole push is toward rural medicine, getting providers in rural areas and taking care of the aged population in Oklahoma, because that's where the health disparities come about, that we just don't have enough providers. I talked to someone at Northwestern recently who had to switch their primary care provider because their provider retired. It was going to be, and this person had insurance, like 11 weeks before they could get hooked up with another primary care provider within their network. Now that's somebody with insurance. That's not a Medicaid or a Social Security patient, because a lot of physicians do limit the number of those kinds of patients they have in their practice because the reimbursement from the government is so low. What's different about the Northwestern DNP program? In the state of Oklahoma, we are the only state university that will have the BSN-to-DNP program. Now, we have DNP programs, we have master's programs in other universities within the state, but it's the only BSN-to-DNP program. So we bring in RNs who have a bachelor's degree, and they exit in 3 to 4 years, depending if they opt to do it full-time or part-time, with a doctorate of nursing practice, and they will be trained to be nurse practitioners. The only other BSN-to-DNP program is at Kramer, which is in Oklahoma City. The cost of that is about triple what it will be at Northwestern. So that's the competition, and all of the students that we are about ready to accept, a lot of them had researched Kramer and said, oh my word, that's a lot of loans and those kinds of things, because it's really, really expensive there. So, as I said, students come in with a Bachelor of Science in Nursing. Seems like we are ready to send the letters out to 25 people to accept them, and those letters will go out this weekend. Most of them have their bachelor's from Northwestern. Probably a third, their bachelor's is not from Northwestern. A lot of them have gone through what we call our BSN completion program, which has been in existence for several years. So students who, say, for instance, graduated with an associate degree to become an RN from NOC or another college, community college within the state of Oklahoma, then come through a BSN completion program. Dr. Wells teaches that program. They can exit with a Bachelor of Science in Nursing in 1 year. And so we really do push students to do that because it makes them more marketable and really expands their horizon. Let's talk about the scope of practice of APRNs. There are 4 roles of nurse practitioners. An APRN stands for Advanced Practice Registered Nurse. It's a kind of a generic term that's used nationwide for nurses that are educated for an expanded role. So the first one is an NP, that's a nurse practitioner. There are all kinds of nurse practitioners, and we'll talk about those in a second. CRNA, Certified Registered Nurse Anesthetist. Nurse anesthetists in the United States administer more anesthesia than MD or DO anesthesiologist. So anybody in here who has had any surgery, it's likely you had a nurse anesthetist that put you to sleep. CNS is a clinical nurse specialist. This is a person who does not necessarily practice primary care. You don't typically go to a CNS office with a bladder infection or a cough or cold or sinus infection. This is a person that works in administration. They can practice primary care, but typically are educators, administrators, those kinds of roles. And then a certified nurse midwife, and that goes without saying, that's somebody that helps deliver babies in, and we're talking routine, non-high risk deliveries. Now, of course, any delivery can turn high risk at the last minute, but typically it's somebody who's healthy and everything's going along without any problems. In most states, nurse practitioners have to have have to pass a national certification exam, and that enables the consumer to know that that person is minimally prepared to be able to practice safely. So what will a DNP graduate be able to do? Primary care. So as I'm a practicing family nurse practitioner. I've worked in a variety of settings, clinics, urgent cares. I work in the school system. We have a school-based clinic, so the school nurse sees, this will turn your hair gray, 60 to 80 kids walk into the school nurse's office every day with broken shoelaces, teeth that have fallen out, sore throats, nausea, headache. Oh my gosh, I feel bad. I have a test that day. And I can say that because we've all done that in high school when we weren't prepared. Gee, I think I have a little bit of a headache. I have to stay home. So working in a school-based clinic in both the elementary, middle, and high school, the school nurse can screen the student. We also take care of the faculty and staff and see, like when strep was going around, they'd call the mom on the phone and, well, Pat's going to go ahead and we'll be able to see your child. Pat diagnoses this kid has strep. We do a strep swab, and the strep is positive. Call up the mom, say, do you want them to have a penicillin shot or do you want them to have medicine? If she says medicine, then I call the medicine into the pharmacy. Mom comes, picks up the kid who has 101 fever and sends him home. And that really relieves a little bit of the pressure within the community because you all know how difficult it is to get into your primary care provider if you're sick that day. You end up going to urgent care or the emergency room, and that's an expensive way to go for these non-emergent kind of things. Okay, a DNP can teach nursing at a college or university that requires a doctoral degree. They can end up in administration. I have one of our applicants really wants to be the chief nursing officer of a medical center. And that would be something that she would be able to do. Sky's the limit. So we are going to be in the business of educating nurse leaders with that additional degree. Program delivery, we are going to be totally online. And back in about 1998, 1999, I had a boss when I was the director of the NADN program, and he was a workforce development guy. He came to me and he said, Pat, I want you to develop an online nursing course. And I laughed at him. I said, seriously? I said, do you want to go to a doctor that got his degree online? Do you want to go to an automotive guy, you know, a mechanic that's learned how to do that online? And that was when online education was just sort of beginning. And no, this is the way to go. I said, okay, I'll make you a deal. I will develop the course. And I'm going to develop it, and I'm going to teach it, and it's going to be a really good course, but I'm going to prove to you this isn't going to work. Well, the interesting thing about it was the students learned a ton. The cheating was truly awful, and we've come a long way in online education. We have all kinds of things. We have remote proctor now, and you have to scan the room and where you're taking your test, and you can't right-click on your mouse to go out to the internet and check the answers. There are lots and lots of things in place that were not in place in 1998. So the cheating is not that big a deal, but the stakes are a little bit higher now, because if somebody's going to be a nurse practitioner and they're going to cheat in their nurse practitioner courses, they will not pass their national exam. And so they will have wasted thousands of dollars of education. So that will be interesting to see. The other interesting thing about online education is we all grew up with, we call it the sage on the stage, standing up there and opening up your head and pouring in the knowledge, and you are writing lecture notes furiously. The average attention span of people nowadays is 7 minutes. That's really optimistic. And if you're anxious or sleepy or you're up all night with night feedings, it's a lot less than 7 minutes. Or the students are on their laptop out on Facebook, or they're on their telephones. So in the classroom with a lecture, we do know that that is the least effective way to teach people. So these are going to require highly motivated students who are going to get online. They will have to do all of their readings, but there's a lot of collaborative activities where they have to work with other students in the class and look at different things. There are a wealth of YouTube videos of professors at medical schools that are giving quick and dirty talks, like everything you need to know about managing somebody with diabetes in 45 minutes or in 12 minutes or whatever the topic is. So all of it will be online. The didactic portion, the lecture portion of the classes will be online, and then they will be doing their clinicals, hopefully within their home areas. So one of the things that I will be doing this summer is traveling a lot to all of the physicians and nurse practitioners all over the state and trying to build some of those bridges, because the chief problem is trying to get people to precept nursing students. They take time. If you're going to do it right. They just take time to teach. So we are admitting RNs from Oklahoma. We admit RNs from other states pending that state approval. Right now I'm in conversations with Nevada. We have a gal who was originally down from around Oklahoma City, has ties to Northwestern, would really like to come through our DNP program, has been a nurse practitioner for 20 years, would like to finish her DNP. So she would come into our program with what we call advanced standing, because she already has a master's degree, and then finish the doctoral courses. We have 2 students that we're going to be admitting who will be like that. Accreditation, a lot of the students say, oh my word, are you accredited? Because of course everybody has to be accredited. Well, the Higher Learning Commission came in to Northwestern in November and gave us their blessing to be the first doctoral program at Northwestern. The Oklahoma Board of Nursing, before I ever arrived, did preliminary approval of the program that was designed by Dr. Wells. And then our nursing accrediting body will come in September of 2018 after we've been in business for a year. Look at our outcomes, look at the grades on the classes and those kinds of things. Make sure all of our policies and procedures are in line. And go ahead and do the accreditation. Timeline, ready to admit our first class. They'll start in August. And we're getting close to when you folks have to get back to work. I'm just going to address a couple more things which you may have heard. There was Oklahoma has really been fighting for what we call full practice authority. You can practice, have an independent practice as a nurse practitioner in the state of Oklahoma. I can hang out my shingle and you come to Dr. Pat Thompson and I will take care of you, I will. But I am limited to only doing things like sports physicals, kids physicals, blood pressure checks, all those, unless I have what we call a collaborative agreement with the physician. And I have to have that to be able to prescribe medication in the state of Oklahoma. So you come to me and you have a bad bladder infection or you have the flu or whatever, I cannot prescribe any medicine for you in the state of Oklahoma without having this collaborative agreement with the physician. The nurse practitioners in Oklahoma have tried over the last couple of years to eliminate that, to be consistent with the half of the other states in the United States that do have what we call full practice authority, that we don't need to have a physician sign off. We have very clear boundaries in education and nurse practitioner, as nurse practitioners. I would not take care of you. I will diagnose your breast cancer or I will diagnose your brain cancer, but I am certainly not going to do anything with your oncology regimen. I'm going to send you to an oncologist. I will diagnose your end-stage kidney failure. That's all these things, we can do that with lab tests, but I'm not going to manage you on dialysis. Okay, so with full practice authority, if you come to me and you have a kid with an ear infection, I can just go ahead and write that prescription without a collaborative agreement with the physician. So there are various barriers to full practice authority on that one slide, and you can kind of read through that. Let me just tell you the end of what happened to House Bill 2013. House Bill 2013 passed the House with flying colors. It was supposed to go to the Senate. The gentleman who was in charge of the Senate committee to hear this bill is an anesthesiologist, which is a physician, and he refused to put the bill on the agenda. So it is dead for this year. It will come back next year, I promise you. And it all comes down to the money. Nurse practitioners in the state of Oklahoma are having to pay collaborative physicians upward to $75,000 a year just to have that piece of paper that says I'm your collaborative physician. There's nothing on there that says they had to review our charts or anything like that. I just have to have this piece of paper. And of course, if you're in private practice and you're paying, even if you're paying $25,000 a year, that overhead cost is passed on to the consumer and onto the health insurance companies. So that is one of the barriers to practice, and this is a nationwide problem. This is not just Oklahoma. And so that is one of the things that our state organization and nationally is working on very, very diligently. So what can you do? If you have has anybody in here ever been taken care of by a nurse practitioner? Okay. So if you like your care by your nurse practitioner, then advocate for that care, okay? If there is anybody who is interested, that you think is interested in either getting their bachelor's degree or are interested in coming in to become a nurse practitioner in our program, just have them get on our website. The website's right there. and I will answer any questions that they have. And the big thing is sharing the excitement. This is a really big deal, not only for Northwestern, but for the state of Oklahoma. Question?
Yes, I'm kind of interested as academic only in this certified nurse midwife. Is that something in the program that might bring deliveries back to rural Oklahoma?
Well, I think the big thing with having worked in what we call a critical access hospital, which Share is not a critical access hospital, but all these little tiny communities that have critical access hospitals, they have eliminated deliveries basically because of the liability, and they can't get OBs to come to that area. Nurse midwives they typically practice in an academic setting, and the people who choose nurse midwives a lot of times are college educated, would really do not want all the interventions that a lot of times a physician will do. And our program is not going to educate certified nurse midwives, but you can get education as a nurse midwife with additional courses, yes. Hopefully it would be really good, because otherwise you're 2 hours away from anywhere that'll do a delivery.
So that would be a maybe.
That would be, if we had more nurse midwives in Oklahoma, that would definitely improve the ability to have better prenatal care and care during a delivery, yes.
And if they had one at Share?
If they had one at Share?
They could deliver babies if she wanted to.
Of course, Share got out of it because of the insurance costs of Share.
Yep.
Well, I wondered about the insurance. That's
Yeah.
why most of them don't have it.
That's why they do not. You're correct. Other questions? Thank you very much.